dose of IV-methylprednisolone for aquaporin 4 or MOG optic neuritis is the present dictum for visual recovery and outcome in optic neuritis patients. In other words, wasting time to start a high dose of IV-methylprednisolone for aquaporin 4 and MOG optic neuritis is a blunder for visual recovery and outcome. There is no financial interest. As per North American optic neuritis treatment trial, the acute treatment of optic neuritis in multiple sclerosis by IV-methylprednisolone accelerates the recovery but does not affect the final visual outcome, thus showing the sense of non-urgency of the treatment in acute phase of optic neuritis. But new era of biomarkers such as aquaporin 4 and MOG positive patients, watershed line starts. The clinical course of optic neuritis differs from multiple sclerosis. Typically steroid responsive, very much steroid dependent, associated with very poor visual recovery and outcome, and poor recovery from each attack of increased accumulated disability. The purpose is to find the role of IV-methylprednisolone, whether the earliest treatment, that is urgency, that is minimum time from the onset of symptoms to IV-methylprednisolone, it results in the best corrective visual acuity recovery after the 3 months. The diagnosis of optic neuritis is based on the clinical history, objective finding as determined by the clinical examination of the neuro ophthalmologist and the paraclinical tests. All diagnosed cases of optic neuritis have to have the diagnosis of aquaporin 4 and MOG associated optic neuritis based on the established diagnostic criteria, that is International Consensus of Diagnostic Criteria of NMOSD in 2015. And it is examined by the commercial cell-based assay. On the basis of our methodology, a retrospective study was performed. Total number of cases is 38, among which 30 are the aquaporin 4 positive and the 8 are the MOG positive. The study is focused on the visual acuity as a functional outcome, not other functional parameters such as visual field and structural anatomy outcome that is as defined in the OCT. Documentation is done for the age of the patient, sex, antibody groups, time to start the IV-methylprednisolone, and best corrective vision at the time of reporting, and the best corrective vision at 1 month and 3 months. At the time of presentation, even if the study antibody status is not known, urgent IV-methylprednisolone for daily dose of 1000 milligram for 3 to 5 days, followed by the oral prednisolone starting at the 1 milligram per kg body weight per day for 11 days and then taper off in the next 21 days. The main outcome measure are 3-month best corrected visual acuity and the failure to regain 20 by 20 or the vision or the vision at 3 months following visual follow-up. This is the data of my study. This broad plots diagram shows the distribution of best corrected visual acuity 1 month for the patient treated with aquaporin 4 and the MOG positive I. And the best corrected vision 1 month in the patient treated with less than 7 days is better than the patient treated more than 7 days. This is the same thing, here the best corrected visual acuity is calculated at 3 months. Here again the best corrected visual is 3 months the patient treated within the 7 days is better than the patient treated after the 7 days. This is the ROC curve analysis, so failure of regain 6 by 6 as a dependent variable. And the predictors are the cutoff time for IV-methylprednisolone, age of the patient, and best corrected visual acuity. When the cutoff time to IV-methylprednisolone as counted individually, then it is the AROC curve. The area under the curve is 8.8. And if you consider the age and best corrected visual acuity at start, then the area under the curve is very low. And so the cutoff time for IV-methylprednisolone is important. So here the Yodon's optimum criteria is the best corrected visual acuity comes when it is treated less than 4 days. When it is the same thing, but where it is the curve analysis for this is 20 by 30. Here again it is said that find that the ROC, the failure to regain vision, if the treatment is within 7 days, is better than if criteria is correct on the age of the patient and best corrected visual acuity at the start. Next is in our study, the patient with the aquaporin 4 and MOG positive optic neuritis respond better if earlier treatment is started. So if if you show if pathology genesis is considered, then irreversible axon damage is starts with the within 5 to 7 days. So supporting our clinical finding with the optimal treatment should be start with less than 4 days, but the treatment before 7 days still offers opportunity for very good visual outcome. So the time is the tissue. It is the core principle that is evolved in the field of neuro ophthalmology. So start the treatment just as soon as we can, but better it is less than 4 days. Thank you.
Excellent one. Excellent, good study. What is your aim of this? Why you want to present this one?
Why?
Is it almost
Because
established
earlier
factor?
it is shown, it is said that in the multiple sclerosis cases, or as I have seen, I have shown you that the treatment.
Could you speak in the mic, Dr.
Yes.
Yeah.
They show that if you start the treatment with IV methylprednisolone, it's a non-urgency, because recovery is good, but again it comes to the in the same position. So the recovery is so after recovery it again back to the previous position. So in that cases, so we cannot find, it is not a non-urgency, but after the AQP4 and MOG positive antibody diagnosis, those cases, if treated urgently and in the high dose of methylprednisolone, if it is within 4 days, the excellent result we can get, even if it is, but the crush is that we should start the treatment as early as possible, because at that time, within 4 days, it is not possible to get the MOG positive or AQP4 result. So it is better to start as early as possible. Here it is an urgency.
Dr. Agarwal, what was your total N size? All those whom you tested but were negative for MOG, NMO MOG?
MOG.
How many were, no, the reason why I'm asking you this is that you can only show relative advantage
Yes.
in NMO MOG
Yes.
of early intervention if we compare it with the group that was
Yes.
optic neuritis but negative for
Yes,
NMO
yes.
MOG. So
Yes.
do you have the data of the
Yes, yes,
non-NMO MOG patients, and can you so compare it with them and give comparative outcomes would give us much.
If you just buy if you can just go for the diagnosis with AQP4 and MOG is very less. AQP4 is you can find in the better number of cases, but the overall is that only the 20 to 30% cases we get the either MOG positive or AQP4.
True. So you have the data of the negative NMO MOG to compare with the current data?
Actually, we go for the all tests you test, but it is find that the only 2 to 3% MOG positive are presented.
Sure. Okay. Any questions, Tanmay? Yeah.
Did you sort of say which type of optic neuritis you'd like to start IVMP even before you got the MOG and the AQP4, because that is going to take time?
Yes.
Or did you give the IVMP to all the optic neuritis patients that you saw?
No,
or was
it
there
is
any criteria for which kind of?
Yes, it is that we should at least go for we examine after the clinical examination. If it is optic neuritis, pure optic neuritis, then there is no problem. But if it is infective, and in other situations where the steroid is not contraindicated, we cannot go for that immediately. Wait for some time. If I get the AQP4 and MOG positive, then we can start with the treatment. But in those cases that are infective, we should not get all this.